Hey everyone, welcome to our second session of the first aid workshops. If you did miss the first one, don't worry because we uploaded it onto YouTube. Our YouTube channel is Dnipro Medical Institute SU. We've also sent out a PDF of our newsletter, Stitch the Gap, which summarizes all the information that we covered in the first session. So yeah, the aim of these courses is just to give you guys knowledge and information on how to deal with emergency situations as like a first response. So for today's session, we're going to go through heart attack, stroke, seizure, and shock. And just a disclaimer that this isn't actually a certified course, but we have done a lot of research into it, and we have trained and experienced people teaching it. So over to you, Juliet.
Right. Hello, everyone. My name is Juliet. I'm a fifth-year med student. So like Bilal said, we're here to talk about emergency situations and how to, help in such situation. So just a little bit about me. I won't take too long. My background is nursing. I've been a nurse for over 15 years. In the last couple of years, I've been working in a GP practice as an advanced nurse practitioner. So I'm hoping that some of the things I'm going to say will be meaningful. But again, just to say, I'm not a tutor by any means, okay, but the information I'm just going to share have been researched and put together from reliable sources. Okay, so what will happen now is I'm going to share my screen. The topics I'm going to be handling today is actually heart attack and stroke. And these are 2 out of the 4 topics that's going to be talked about today. So just hold on 1 minute. Let me share my screen. Okay, can you all see my screen?
Yeah, we can see it.
Yes.
Okay, thank you.
Yes.
Okay, so like I said, heart attack and stroke. So just briefly, as medical students or dentistry students, it would be good to just have a quick overview of what we're talking about, instead of just diving straight away into heart attack. So I just thought it'd be nice to have a quick look at the heart, really, and before seeing what's happening there. So the content of what we're going to talk about today, not in details, really, heart overview, definition, risk assessment. So these are the content of what I've made. Again, I'm not going to go into details in all these things. This is not a lecture on heart attack or stroke, but I'm sorry if you come across that way, but that's, the main focus is just on emergency care or aid, okay? So this, again, as we can recognize, is the heart, and what it does is it just pumps blood into the entire system, and if anything happens to the pumping function of the heart, there's obviously going to be an issue to the whole system, really. Anatomy of the heart vessels. So mainly in terms of heart attack, where the problem is on the coronary artery, which are the arteries that supply the blood to the heart, which is the left and the right coronary artery. Now, most of the heart attack that happens, from research, 78% of the heart attacks actually happens on the left side of the heart, which is where the left anterior descending artery is. Again, a little bit more information on the artery is on the PowerPoint, so I'm not going to go into details on that, but I've just put the information together, okay? So this is what we're dealing with, heart attack, which is a sudden blockage of blood flow to a portion of the heart. Like I said, the right and the left coronary artery, so when it's completely blocked, there'll be reduced or no blood flow and oxygen to that heart, the part of the heart. So which will cause the heart to, to stop functioning. Medically, we call it myocardial infarct or heart attack, as we simply call it. The longer the damage, the more irreversible the damage. The longer the stoppage of the blood, the longer the damage will happen. So I just put two keywords here. There's angina and cardiac arrest. These are actually words that you come across very frequently with heart attack. Angina is very similar to heart attack, but is a very short-term blood supply stoppage or partial blockage of supply to the heart, as we call it mini heart attack. So, but it doesn't cause irreversible damage like heart attack does. And cardiac arrest, again, is completely different from heart attack. It's an electrical malfunction, really, not a blood flow situation. So incidents, like I said, I'm not going to go into details, but I've put information here. But all I want to say is heart attack is something that happens, like every few seconds. Is quite common. We will come across it, like in our daily lives, not because we're medical students or dentistry students. Just in America, every 40 seconds, somebody has heart attack, every 40 seconds. And one in every 5 minutes, one happens in the UK. But across the whole world, 17.3 million people have heart attack every year. So it is very, very common. Risk factors, I just thought I should mention this, even though, like I said, we're talking about emergency situation. So there are changeable and unchangeable risk factors. The older we are, the more risk we are at having heart attack. Genetic factors plays a huge part. If there's family history of stroke or heart diseases, you will be at higher risk of developing heart attack. Race, unfortunately, American, African, Hispanics, these are, they have higher tendency of having heart attack. Men, as in sex, are at higher risk. But then, funny enough, postmenopausal women tend to equal the same sort of risk, or even sometimes more. These risks down here are changeable. So our lifestyle, really, which we can control, medical conditions and stuff like that are factors that play a huge part in heart attack. So, but the direct cause is basically an occlusion, like I said, is a blockage of blood flow. So, and the main things that blocks the blood flow, we have the cholesterol, which we call atherosclerosis, or thrombus or embolism, or maybe like a spasm that happens in the arteries and causes a closure. So these are direct causes, as well as trauma, and these are they don't really, it's not something that happens often. The 78% of heart attacks are caused by occlusion to the heart's arteries. So, and I'll just put a picture here. Again, I'm not going to go into the pathophysiology and all that, but in case if someone wants to have a look later on, you see the embolus and the atherosclerosis and all that business there. Now, symptoms. So this is where the emergency aid, what we're talking about today, what we'll be looking out for as individuals, as medical students, as dentistry students, what we'll be seeing when we start acting to support a patient or somebody that we see that we think have got symptoms of heart attack. So chest pain is the cardinal symptom. So you will see someone clutching onto their heart, is usually a heart chest pain. That's the main thing. People describe the pain as different ways. Some people will have it as heaviness, burning sensation, crushing, you name it. And a lot of the time it radiates to different parts of the body, like the neck, jaw, and stuff like that. So one thing I'll mention is, like when I said about the pre-risk factors, people that have cardiac problem like angina, as I mentioned before, they'll obviously be on a medication called GTN spray. But one thing that you use to identify the difference between someone having an angina pain and a cardiac pain, heart attack, is even when they use the GTN spray, it doesn't help relieve the symptom of the chest pain. Now, that obviously is not angina, is obviously a different condition we're dealing with, which is a heart attack, a suspected heart attack. So other symptoms, patients who have anxiety, they will have this feeling of doom. Obviously, when something is happening to your heart, you'll be worried, oh my God, what's going on? So the fear and apprehension is actually quite common. They will have sweaty feeling, pale, and all that, shortness of breath, nausea, vomiting. So a lot of all these symptoms are actually classical of a heart attack. And this is where we come into play. When we notice someone going through this situation, what do? You obviously come to their aid. You help the patient to, sit in a comfortable position or in a safe place, depending on the environment where the issue is happening. You call for help. Calling for help is not shouting for a neighbor. You use your phone and call the ambulance. And what you'll be saying is, I think there's a heart. You're not confirming the diagnosis. You are suspecting this is an emergency situation. So you're calling for help and saying, there's someone here, I think they're having a heart attack. While you've called for help, you support the patient or the client or whatever you call them, the individual really, support their head and shoulder, get them to know that I've put this picture here, what to do, put them in a comfortable position, give them aspirin, 300 milligram if there's aspirin available, but they have to be over 16 years of age and they're not allergic. Help them to take angina medication. This is if they already have angina and the medication with them. They have to be carrying the GTN spray wherever they're going if someone has angina. Encourage the patient to rest or basically reassure the patient. Monitor their breathing, pulse, and level of response in case if their condition deteriorates. And while you wait for help to happen, to come. I'm just going to play a quick 2-minute video or something just to reiterate what I just said on how to assist someone in an emergency situation. Okay, just give me one take.
Heart attack. If you suspect someone's having a heart attack.
Okay, are you seeing my screen still? Yeah.
Yeah, we can see it.
Okay.
The signs might be that they're pale, cold, clammy, feeling sick, feeling thirsty. Maybe they've just had an aftershock, or maybe they're at rest and they suddenly feel incredibly ill. Keep everyone as calm as you possibly can. Encourage the person to sit on the floor in an upright position because they're likely to be breathless. And if they're happy to do so, put something under their knees to put them into the lazy W position like this. Because that gives them a little bit of extra blood to their heart, but not too much. Support them like that, or lean them up against a wall. If they have a GTN spray, because they've got a history of that heart problem, then you should encourage them to use it now. They would shake it and they would spray it under their tongue. If they've been prescribed a 300 milligram aspirin, they should also be taking that as well, and they would chew it. If there is a defibrillator to hand, discreetly ask somebody to get it. So if you're in a work environment or you're somewhere near where there is a defibrillator and they're clearly signed up, then you would ask someone to get it, put it out of sight of the person so as not to alarm them, but then you've got it so that if they do collapse and you need to use it, you have it to hand. Keep everyone as calm as you can, get an ambulance on the way quickly, and that will give them the best chance to perform.
Okay, so that's what I just explained in a nutshell, but in a video kind of situation. It depends on the environment where you are. If you are at the road or you notice someone in the shop having symptoms, obviously you're not going to have pillow and all those sort of things, but you can just try as much as possible to make them calm and sit them down at the, in a safe place really, where people will not be going and coming and looking at the situation as if it's a show or parade, really, if you can. So that's emergency aid for a heart attack. All you need to do is call for help, support the patient, give them aspirin if there's one available, GTN spray if they have one, and all that. So that's basically the emergency help that we can render. I've put some information together here. Again, like I said, hospital management, what happens when the ambulance take the patient and off they go to hospital. So there's a whole lot of things that goes on. I'm not going to go into details. This is not a lecture on stroke or heart attack, but I just thought if I put some information there, if someone is interested, can have a quick look. Complications of heart attack, obviously anything that happens to the heart is bound to have some after effect, and they're not usually pretty stuff. So that's heart attack in a nutshell and the emergency aid. Okay, so moving on, the second topic, like I said before, is stroke. Okay, I've put some references, the information I gathered and where I sourced my information is stroke. Okay, so again, I've done the same thing with what I did in a heart attack, a bit of a view of the brain, really. Again, not in detail, I'm not doing an anatomy class. The brain is, comprises of the cerebellum, and the brainstem. And these parts of the brain, they have different functions of the body. And if any damage happens to the brain cells, depending on the area of the damage, it will affect the function of that, what that area carries. So like, for example, cerebrum helps in the vision, hearing, speech, and all whatnot. So you can imagine if anything happens to the cerebrum side of the brain, you will be having an effect on those functions. Cerebellum, the movement and the posture, and then brainstem. This is dangerous if a stroke happens here, because it kind of controls the human life, really, the heart rate, the breathing, and stuff like that. So if any stroke that happens around the brainstem will have catastrophic effects. Okay. Again, a little bit of arterial supply to the brain, which I found interesting. I thought I'll just put some information there. The main supply of blood to the brain is by two main arteries, which is the carotid artery, internal carotid artery, and the vertebral artery. So this is the common carotid artery, which at this point bifurcates into internal and external. So the internal carotid artery and then the vertebral artery, which is here, they join together here to supply the brain. Those are the two main sources, and the anastomose to form what we call the circle of Willis. So what I just want to mention briefly is when they branch out, they supply different parts of the brain. So like example, now middle cerebral artery supplies the temporal side of the brain, and the anterior cerebral artery supplies the frontal lobe of the brain. So imagine if there's a stroke that happens to the middle cerebral artery, the temporal part of the brain will be affected, and whatever function that aspect is holding as a job in the body will be heavily affected. So moving on, stroke, like I was saying, is as we call it, CVA, cerebral vascular accident, is a disease that affects the arteries that supply the brain cells, and it causes neurological defects that happens or persists after 24 hours. The reason after 24 hours information is what we call TIA, transient ischemic attack, is the same neurological deficit that is similar to stroke, but the effect doesn't last for up to 24 hours or more than 24 hours. So these are the two difference. These are the difference between TIA and stroke. So again, incidence, I'm not going to talk much about it, but it happens a lot. It does. Okay, so you'll be coming across it quite often, whether it's when we're out and about or when we're in clinical settings. Risk factors, very similar to what I talked about before in heart attack, age and all those information, medical condition that predisposes people to having stroke, high blood pressure, just like I mentioned earlier, and all those things. But a lot of the factors are actually changeable because of the lifestyle related. So types of stroke, ischemic stroke and hemorrhagic stroke. ischemic is mainly the more percentage of stroke that happens. 85% of all strokes are ischemic, and that is to do with blockage of blood flow, really, just like we have in heart attack when an embolism or maybe thrombus occludes the artery. You can see that that's an embolism and thrombus, so when the supply of the blood to the brain or part of the brain is occluded, then we have a problem. The other type is hemorrhagic, when there's a bleed. So coming to what we're dealing with, which is an emergency situation, what do we do when someone is showing signs of stroke? Now, most of the symptoms that, or maybe the acronyms that we find out and about on the news or, information out there are usually fast. But I found this and I thought that's actually interesting, because it's not all the time someone will be sitting down and you'll be looking at their face and stuff. Some of them could actually be standing. So you notice loss of balance or dizziness of headache, and they have blurry eyes, or no, sight will be, will have the sights will be going a bit, and then they fall. People actually fall down from walking and they have a stroke. So it's not always in a comfortable sitting position and their face is droopy and all that. But these are the, clinical signs when one side of the face is drooping and the arm is weak, or they can't raise one arm as high as the other, and the speech is slurred. Now, the T is obviously not a sign or symptom, but it's time to ask for help, okay? Other symptoms I've put down here. Apparently, women present more symptoms than men when they have stroke. From this information gathered here from Stroke Association, women tend to have headaches or maybe general weakness, disorientation, fatigue, and all that when they have stroke. But men will have some of these symptoms, which both men and women do have, but women tend to present with more symptoms. And emergency aid, what do we do? Okay, a stroke patient can be conscious. Most of the time they're conscious, but they can actually become unconscious as depending on the how worse this, how bad the situation is. So when you see a patient that you think maybe they were just walking and all of a sudden they start staggering and all of a sudden they're on the floor, you obviously come to their aid, ensure that they're in a safe environment, talk to them calmly. You can identify who they are, ask them, what's your name? Or if it's someone that you know already and you're sitting with talking before the symptoms happen, you just keep talking to them calmly and call for help. On the phone, you be telling them, I think this patient is having a stroke. There's something that I read that called, what we talked about, the FAST test. So quickly, when all these things are happening, the FAST test is you're looking at their face, and you can see there's a disparity in the face muscle. The one side will be drooping. Let me just go back to that FAST. So their arm, you ask them, can you raise your arm up? You will notice that one arm can be raised easily and the other one obviously weak. And the way they'll be talking to you, you will notice that their speech is a bit, there's a difficulty in them understanding you or talking. So this is a FAST test. So when you're calling the ambulance, you can tell them, I've done a FAST test and it's showing, I think this patient is having a stroke. So you can tell them that straight away, because this information is very important. When they're sending ambulance out, the way they group emergencies, they call the 1s and the 2s and the 3s and all that. So they will send help out quicker, because time is key in stroke management. Reassure patients, loosen their clothing, or maybe just keep them warm. If they're wearing tight clothing, you want to loosen it up a bit just to aid blood flow. Place them in a comfortable position, preferably lying them down with their legs just slightly raised to aid blood flow. Do not give them anything orally. Unlike heart attack, if we remember, you're offering the patient to have GTN spray, you're giving them aspirin, but in this case, do not give them anything orally, because the airway or maybe the swallowing reflex may be affected and you'll be causing more harm than good. Monitor their condition closely because, like I said, even though they might be unconscious, they can drift to an unconscious state quite quickly. But if the patient is unconscious, move them into a recovery position, monitor their airway and chest movement. You lift the position, the patient's chin. What this is a typical recovery or resuscitation state, which I think we did last week, or what you do when a patient is unconscious. Listen for breathing sounds and place your mouth or cheek over their mouth to feel for breath. If there's no sign of breathing, you start CPR straight away as fast as you can, really. So I've got a quick video here. It's only like 2 minutes or less even. Let's see.
In this video, you'll learn to recognize the signs of a stroke and what to do. A stroke is a problem with the blood supply to the brain. The signs of a stroke appear suddenly. The face drops, becomes asymmetrical or distorted. The casualty has trouble speaking. The casualty has a weakness or numbness in one arm or leg. The casualty may have a headache. The casualty has difficulty seeing. Make the person comfortable and have them lie down if possible. Call the emergency services as quickly as possible. The faster they receive treatment, the less likely they are to suffer serious consequences, including death. Make a note of the time the first signs of the stroke appeared, as this will be important for subsequent treatment. Make sure the casualty doesn't make any physical effort or eat or drink. A stroke victim may have trouble swallowing. Keep a check on their state of consciousness and breathing until medical help arrives.
Okay, so again, that put that in a video, for us to visualize what I briefly talked about on what to do in a situation where we find someone, a relative, a friend, or a stranger even, where we suspect stroke. So simple measures, just put the patient in a comfortable position and in a safe place, call for help and monitor. So like I did before, I just put together some information on what happens when the ambulance takes them and they're off to the hospital, some of the assessment and management of what will be going on. But stroke is such a huge condition that will change a patient's life completely. So even though heart attack is bad, stroke is even a worse situation. So the faster we can act, the better chances of a patient surviving even, and then surviving with less disability that happens. So I've put, like I said, some information I put here. They're not really emergency aid related, but I just thought if someone wants to have a look at what happens or goes on. Like I said, we're medical students anyway, so why not? And the complications of, stroke. So, but the aim of the topic today is emergency aid, and that's where we're going to keep it at that. So I hope this was informative enough. And I've come to the end of the presentation. So if anyone has questions, feel free to ask. I hope I can answer them. I'll do my best, and if not, I'll leave them for the able-handed, people that are our doctors that obviously have more knowledge and are trained to talk more about these. Okay, so thank you very much for listening, and yeah. So I don't know if we have anyone with questions. Okay, all right, so I can see, right, hold on, let me have a look at the chat here. Okay, let's have a look. Both heart attack can lead to death and disability. All right, so I'm just going to take the first question here. I'm trying to read through. What is more worse, a heart attack or stroke? Okay. I think I should really scroll up. Why does paralysis occur mostly on the face on heart attack patients? Now, paralysis, okay, let me go to that one first. That's the first question. Paralysis doesn't mostly happen to the face only. It actually happens the side of the body that is affected. So if it's the left side of the body that has, okay, going again to anatomy, the side of the brain that is affected, that is occluded, actually affects the other side of the body. Now, this is way too complicated, but if you have paralysis of the left side of the face, there is 100% chances that you have paralysis of the left hand, the left, depending on how bad the stroke is. So you won't just have the paralysis of the face. I don't know if that makes sense, Ariana, but when there's drooping of the face, if it is the left side of the face, the left side of the left hand, the left leg will also have weakness, because that's the track that, like I said, the part of the brain that controls, the body. So if it is the cerebrum that is affected, so the face and I don't know whether this is making sense, but that's if there's a left-sided face weakness, there's likelihood there will be a left-sided arm and leg weakness. Okay. So that's the first question. The other one says, what is worse, heart attack or stroke? Okay. I don't want to put it in a situation where I'll say stroke is worse than heart attack, but actually, in the right sense, yes, stroke is. But heart attack, when you have a heart attack, it will put you at a higher risk of developing stroke, because one of the complications of heart attack is irregular heart, which we call arrhythmia, like arterial fibrillations and all those irregular arrhythmias, really, that's the name. And what they do is they'll be firing the blood, so the way the heart pumps the blood, you are high risk of developing blood clots, which obviously can travel up the carotid arteries and occlude the blood supply to the brain. So, and the stroke can lead to death. I mean, both of them can lead to death, but heart attack can cause stroke, not the other way around. So I suppose stroke is worse. Yeah. So I think that's it, Bilal.
Yeah. I think that's it, yeah. Thanks for that, Juliet. That was very informative. So now we're going to move on to our second speaker. It's Christina, who's going to be talking about seizure and shock. So take it away, Christina, if you're here.
I'm going to take these off because they are reflecting. Hello, everyone. My name is Christina, and I am a fourth-year medical student. I've also done my certification courses in BLS and ILS, so not as qualified as Juliet, but let's see how it goes. Today I'll be covering shock and seizure. So I'm just going to share my screen and let me know if you guys can see the presentation. Okay. Can you all see the first screen?
Yeah, we can see it.
Okay, perfect. Okay, cool. So today we're going to be covering emergency care for patients who are experiencing shock and seizure. So first of all, we'll start off with shock. And like Juliet did, I just thought I'd give a quick overview before we get into the emergency treatment. So first of all, what is shock? There are three types of shock. You've got your hypovolemic shock, your cytosomatic shock, and electric shock. So hypovolemic shock is when there is a reduction of blood flow and the vital organs don't receive enough blood, which can lead to organ failure and then heart failure. Cytosomatic shock is when a patient goes into a state of shock after experiencing a traumatic event. So, for example, seeing an arterial bleed, being in a traumatic accident, witnessing a loved one pass away, and then you can get electric shock. So electric shock we will cover in an emergency aid video at a later stage, but for now we are going to be treating patients who have either gone through hypovolemic shock or those who have gone through a cytosomatic shock. So the cause of shock, like I said, is anything that reduces the blood flow to the vital organs of the body, and this can be due to severe bleeding, so internal or external. So internal bleeding, for example, if the patient was in an accident, like a car accident, or had a fall, or had some form of trauma to the body, and then an external bleed, you will often see this bleed. So for example, if a patient has cut themselves and has an arterial bleed, if a patient has lost a lot of blood, like I said, you'll be able to see, on the extremities if the patient has an external bleed. Another problem that can cause shock is heart problems. So anything that reduces the heart's ability to pump blood around the body, such as a myocardial infarction, this will lead to shock, as well as a loss of bodily fluid. So if the patient has severe diarrhea, severe vomiting, or if they have severe burns, such as a 3rd-degree burn, they can also enter a state of shock. So what we need to know when dealing with patients who we suspect have shock is what to look out for. So important to note that patients who are experiencing shock will have a fast pulse. They'll often have pale or cold, clammy skin, so they'll look like they have almost like a thin veil of sweat over them. They'll be sweating, they'll have very fast, shallow breathing. Their skin might have a bluish grey tinge to it, so a cyanotic skin color. Very important within the lips and the oral mucosa, it will be a bluish tint. The patient could be experiencing weakness or dizziness, as well as nausea and thirst. If the shock is more severe and progresses, your pulse can actually decrease. They can become restless or aggressive, as well as gasp for air or become unresponsive. So I'm just going to do a quick demonstration for you on what we should do when a patient is experiencing shock, and then I'll show you guys a quick YouTube video. And for this, we have Joel, who's going to be our dummy for today. So I'm going to show you guys what to do when a patient is experiencing shock. So I'm just going to move the camera so that we can put you guys in the view quickly. Okay, cool. Can everyone see? Perfect. Okay, so our patient, okay, move that way. Okay, perfect, cool. So our patient today has experienced hypovolemic shock, and they have an arterial bleed. So the first step that you're going to do is you're going to treat the source of the shock. So in the next video, we'll be doing an emergency aid course on how to treat bleeding. So let's assume that we've localized the point of injury, we've stopped the bleeding, and now we're going to treat the shock of the patient. So what you're going to do is, once you've treated the source of the shock, you're then going to gently lie the patient down while reassuring the patient the entire time that everything's going to be okay and keeping them calm. So you're gently going to lie the patient down. You're going to say everything will be fine, take deep breaths, and then what you're going to do is you're going to take a chair or any object that will allow you to elevate the feet. So this could be a cardboard box, a stool, a crate, anything on hand, bring it towards the patients and just elevate their feet onto the surface. So you're going to gently bring the feet up and you're going to place them on your object so that the feet are elevated above the level of the heart. Now, the reason why we want to do this is because with shock, there's a decrease in blood flow to the vital organs. So by lifting the legs, we're increasing the blood flow to the heart and the vital organs. The next step that you want to do is you want to find some form of insulating material. So whether that is a blanket or a sheet, you can use, if you have a jacket on you, or sometimes first responders use newspaper or cardboard. So what you want to do is you want to take your blanket. We have a nice blanket here. And what you're going to do is you're going to place this on top of the patient who is experiencing the shock. And you're just going to cover the patient so that their entire body is covered. And the reason why we place the blanket on the patient is because when you go into a state of shock, obviously your extremities become very cold because there's a reduction of blood flow. So what does our homeostatic mechanisms do? It tries to increase the blood flow to the extremities to warm up the surface of the skin. And then this is obviously problematic because it further reduces the amount of blood flow to the vital organs. So we place the blanket on top of our patients so that we can increase the temperature of the surface of the skin, thereby decreasing the need to send unnecessary blood flow to the extremities and therefore increasing the amount of blood flow to our vital organs. So now that your patient is covered, what you're going to do is you're going to call emergency assistance, so 911, 000, whatever your local emergency assistant number is, and you're going to continue to monitor the patient for their responsiveness, make sure that they're breathing, opening up the airways. And then important to note, you shouldn't lift the patient's feet if they have a leg injury or a spinal cord injury, as this can cause further damage to the patient. So thank you very much for being our dummy. I'll now show you guys a quick video about pro CPR and then we'll move on to seizure. Okay, let me just see if you can all see my screen. Okay, can you all see?
Yeah, we can see it.
Yes.
Cool.
Yeah.
Christina, we can't hear it.
Sorry, I muted myself, hold on. Okay, can you hear now?
Now let's cover shock emergencies. In this scenario, we had an individual who was bleeding from an arterial wound and lost quite a bit of blood. Now, they didn't pass out, but they were starting to feel dizzy and lightheaded. So we helped lay them to the ground, and now we're going to be suspect that they either are going into kind of a psychogenic, psychosomatic shock, which is more psychological because they've seen all the blood and they're concerned, or they might have lost enough that they're having some hypovolemic shock, which means low blood volume. Either way, the symptoms are the same, and we're not going to take a chance. We're going to treat them. Gloves are on, our shield is available with a one-way valve, and we've checked for scene safety. The scene is safe. They are responding to me. They are breathing normally, and they do have a pulse. So it's still something where we're trying to decide, do we call 911 or not? But as soon as I see that they're pale, that they're starting to lose a level of consciousness or going to pass out, in my opinion, that's time to call 911. You in the plaid shirt, go call 911 and come back, bring an AED with you if you can find one. And so now we're ready to begin treatment. I want to reassess like I just did for normal breathing and for a pulse. But now I see that they're a little pale. I squeeze the nail bed and turn it white, and then I let go. It takes longer than it takes me to say capillary refill for it to refill. This is an early sign of potential shock. To treat this, I'm now going to explain to my patient what's going on. I'm going to elevate their legs. It's important that you just find something that's 6-12 inches high. It doesn't have to be super high, but you could use a stool, a chair, a box, whatever you have available. I have a blanket here, but you wouldn't have to necessarily use a blanket. You could use coats, you could use newspaper, anything that helps maintain the body temperature of the person that is going into shock, because this is going to help maintain their core body temperature. When they start going into shock, their body shunts the blood from the extremities and brings it back to their vital organs. This makes them very cold to the peripheral. When this happens, the body will only take so long before it thinks it needs to reheat the rest of the body. When it does that, it will vasodilate, and the blood pressure that they do have could drop again. So we want to help combat that by keeping them warm, comforting them, and watching for regular breathing, making sure they're awake. And if they ever change, lose their breathing, lose their pulse, we're going to respond with CPR and wait for EMS to arrive.
Okay, can you guys all see my shared screen again with the presentation?
Yes.
Yeah.
Cool. Okay, so I hope that cleared up how to treat a shock in a case of emergency. We're now going to move on to seizures. So this is just a quick demonstration recap. I have sent the PowerPoint presentation to Keisha, and she will email it out to you guys so that you have access to the PowerPoint. But this is just a quick recap on what to do if a patient has experienced shock. And then just to recap what we did last week with regards to the doctor's ABCD, this is the first step that you take when approaching an emergency situation. So if you guys want to read through that real quick, you're more than welcome to. So just to remember and highlight, when someone's experiencing shock, it's really important to treat the cause of shock initially, lay them down, raise their legs, call for emergency help, loosen any tight clothing that could cause further restrictions to the patient, as well as keep them warm and calm and monitor their level of response. So we're now going to move on to seizures. So what is a seizure? So a seizure is also known as a convulsion or a fit, and this is basically when there's a disruption to the electrical activity in the brain. And this can lead to an uncontrollable contraction in the muscles, as well as unresponsiveness. So as we all know, the most common cause of a seizure is epilepsy. However, it can be caused by the following, such as alcohol poisoning, lack of oxygen, following a head injury, taking certain drugs, as well as when diabetics are in a hyper state when they have low glucose levels. So what to look out for if your patient is experiencing a seizure. They become suddenly very unresponsive. Often their eyes roll back into the back of their head, or they have like a glazed look over their face. They have a rigid body, an arched back. They often have a difficult time breathing, and they can have very labored breaths. They can have convulsive movements. Some patients salivate at the mouth, and this can become bloodstained if the patient has bitten their lip or cheek or tongue. They often lose bladder or bowel control, and it's very common for them to fall into deep sleep after the seizure has taken place. So I'm now going to do a quick demonstration with regards to how to treat a patient that is experiencing a seizure, and again Joel will be our dummy for that. So we're just going to reposition you guys so that we can show you the quick demonstration. Okay. So Joel, oh, can't see. Okay, cool. Okay, so Joel is going to be demonstrating someone who's having a grand mal seizure, also known as a tonic-clonic seizure. So the first thing, when your patient is having a seizure, it is very important to clear the area so that they don't further damage themselves. So any objects that could cause further harm to the patient, you need to remove from the vicinity. Then what you're going to do is you're going to take any form of cushioning, such as pillows or some clothes or something like that, and you're going to place them around the patient's head so that you avoid causing further injury to the patient. You're then going to time the seizure from the beginning until the end. It is very important not to restrict the patient while they're having a seizure, as this could cause further harm to the patient, as well as do not put anything into their mouths. It is a misnomer that you should often put a spoon or a wallet or water into the patient's mouth while they're having a seizure, and this is definitely incorrect. You can cause further harm to your patient. So it's very important to create a safe environment for the patient and let them finish having their seizure. Now you can see the seizure stopped. Take note of the time and the duration of the seizure. Now that the seizure is stopped, you're going to roll your patient over and check that they're breathing. So you're just going to tilt the head back, and you're just going to monitor the patient's breath. So our patient is breathing, and now what we're going to do is we're going to put the patient into the recovery position just in case they vomit preceding the seizure. So what we're going to do is I'm going to do a quick recap of the recovery position that we learned last week. So what you're going to do is the arm closest to you, you're going to extend fully. You're then going to take the opposite arm and place it over the patient's chest, close to their ear. You're then going to lift the leg further from you up, like that, arching the leg. You're then going to gently roll the patient over, minding their head onto their side. Making sure that the leg that you lifted becomes a stopper for the patient, and then placing their hand under their head to lift it up. It's also very important to lift the head back or tilt the head back just to open up the airways. You can now leave the patient in this position and monitor their level of response. If the patient becomes unresponsive, you then need to prepare to treat an unresponsive patient. Once the patient is in this position, you can call for emergency help. It's very important to call for emergency help if this is the patient's first seizure that you know of, if the patient is pregnant, diabetic, or if the patient has caused severe bodily harm throughout the seizure. Also, if the seizure occurs multiple times, for example, in the state of status epilepticus. Otherwise, just keep the patient calm in a safe environment and stay with the patient until the patient becomes responsive again. Okay, thank you. Ooh, okay. So I'm just going to show you guys a quick video.
Now let's cover seizures for the adult and what to do when it happens in the workplace. So when a person goes into a seizure, they could have gone into that for so many different reasons, it's unbelievable. So to focus on why it happened is not the bigger point. The fact is recognizing that it did happen. We saw that she went into what we call a tonic state. Hands were gripped, they were pointing towards her body, she was seizing actively, and then went into what we call a postictal state or a relaxed recovery state. While the patient is actually seizing, it's important to do a few things. Make sure that whatever is around them is not going to actually harm them more. So if there's sharp objects that they could bump into while they're seizing, we want to either move the object or move the patient so that they don't get hurt further. If they seem to be having what we call as a tonic-clonic seizure, where they're contracting and relaxing, they might be banging their head on a hard surface like the cement floor. It's important for us to protect their head, which we can do by cupping our hands to just give them a little cushioning so that while they're actively seizing, they're not also causing a head injury. Now, once the patient has come out of the seizure, we need to assess a couple things. One, has EMS been activated? As soon as we see they're in a seizure and we don't know that they're an ongoing epileptic, they don't have any standing rules, we're going to call 911. But if we are near the patient and we can send somebody to do that, we will be using that time then to assess them for whether or not they're breathing or whether they are moving and beginning to come back to consciousness. If this patient is not breathing and not moving and doesn't respond to our taps and shouts, we're going to go right into CPR and call for an AED. If this person starts to breathe, which is fairly normal during the postictal state, we're going to assess them to see, is this agonal respirations or are they breathing more in a corrective measure? If they are beginning to breathe, then we're going to go ahead and do the recovery position to help keep their airway open and clear while they recover from the seizure and we wait for EMS to arrive. The way that we do this is we elevate the arm closest to us up over their head. We bring the furthest leg away over and we cross their legs, grabbing their wrist and their hip underneath their head and neck. We roll the patient onto their side. We lift their head, untuck the hand, and bend their arm up underneath their head. Notice how they now have a face that's pointing towards the ground, allowing gravity to help clear their airway. We then bring their knee up as a kickstand to help protect them from rolling all the way over. If they seem to be showing signs of shock, like cool, pale, sweaty, rapid pulse, we can cover them with a sheet coat or blanket and allow them to recover. While we're waiting for EMS to arrive, we're going to be assessing for breathing and for recovery signs. Maybe they're talking to us. Maybe they're saying, what happened? Maybe they're saying, oh, my head, it really hurts. But any of that stuff is good signs that they're recovering out of the seizure. Make sure you understand that a seizure patient is low on oxygen. They're confused. They had an electrical storm in the brain, and they might be confused. They could even be combative. They might want to try to get up. They don't know where they're at, and that can last for a few minutes. So just don't try to hold them down during a seizure. Don't stop them from seizing. Just help support them and protect them during the seizure, and then help assess them for more serious situations like cardiac arrest while we await EMS to arrive.
Okay, so I hope that cleared up what you need to do when a patient is experiencing a seizure. This is just a quick recap. For all of you who just want to read through it, I'm not going to go through it again, as well as a quick recap on the recovery position. There are one or two ways to do the recovery position. In the video, he demonstrated he put the arm above the patient's head and then rolled them over. Other practices prefer to put the arm straight out and cross the chest. It all depends on what your preference is as well. So this is what St. John's Ambulance recommends for the recovery position, but whatever you've been trained to do is also acceptable. So remember, if someone is experiencing a seizure, it is really important to protect the casualty. So make sure that the area is completely void of anything that can cause them further damage. It's very important not to restrain the patient. A lot of people try to restrain people who are having a seizure. This can cause further damage to the patient, and it's highly advised not to. Again, do not put anything in their mouths. No water, no wallet, no spoons, no keys, nothing. Leave the patient and let them seize. Support their head if need be, so with some cushions. If you don't have anything on hand, you can form a cradle and cradle their head while they are seizing without restricting them too much. And like I said, don't put anything in their mouth and call emergency services. So I hope that explains to you guys what we should do in the case of a shock or seizure. And a few students sent me questions earlier on, so I just made a quick slide with 3 Q&As that we can quickly go through. So the first one were, what are the types of seizures? So there are a lot of seizures available. There's a lot of seizures out there. So you can have petite mal seizures as well as grand mal, which are your tonic or convulsive seizures, which is what we saw in the video, as well as what Joel demonstrated for us. You have atonic seizures, clonic seizures, tonic seizures, and myoclonic seizures. Then the difference between tonic and clonic is when you have the stiffening. So that's when the extremities become very rigid and pointed outwards. And clonic is when you're twitching or jerking. So when the patient was very, very stiff and they were twitching and jerking, that's known as a tonic-clonic seizure. Then for IV fluid, so as a first responder, you're not necessarily administering this, but once the patient is administered an IV, adults are normally given 1 liter of crystalloid IV solution, or in children, it's 20 milliliters per kg. And then in the case of hemorrhagic shock, for example, if there was an external bleed, the patient is often given 5 to 10 milliliters per kg of colloid or RBCs. So I hope that answers all your questions. So yeah, thank you so much.
So yeah, thanks for that, Christina. That was really educational and interesting. So yeah, that's it for today. Like the first session, this is being recorded, and we will make a PDF leaflet with all the information that was covered today. Yeah, so make sure you join us next week for our 3rd session, and thank you all for joining. Stay safe.